Hello all, I am Dr. Kanagarajan. I am a Senior Consultant Cardiac Anesthetist at Madras Medical Mission Hospital, Chennai. The topic which we are going to discuss today is about the management of circulation, especially after systemic to pulmonary artery shunt, either in patients with biventricular physiology or single ventricular physiology. I hope some of us will be able to identify this person. He is Dr. Merrill Harmel, and he was the first anesthetist. He was the anesthetist who had given anesthesia to the first patient. Congenital heart lesions resulting in a single ventricular physiology account for up to 30% of the congenital lesions, and they are usually associated with the high mortality, especially in the infancy. These lesions are characterized by inefficient parallel circulations and the volume loading of the single ventricle and arterial desaturations. And these patients will require staged palliations, either BT shunt followed by Glenn shunt, then Fontan completion, or bilateral Glenn shunt, then going for a Fontan completion. If you look at the indications for systemic to pulmonary artery shunt, the basic aim is to increase the blood flow to the lungs. The blood flow to the lung is provided by a ductus arteriosus in cases like tricuspid atresia, pulmonary atresia, and tetralogy or fallow. And in few conditions, the blood flow to the body is provided by the PDA, especially in hypoplastic left heart syndrome. And in other lesions where the pulmonary arteries are small, they may require a BT shunt. Usually, systemic to pulmonary artery palliation in neonates is associated with high mortality and morbidity. The mortality in a single ventricle patient is around 15%, and in patients with the two ventricle, it is around 3 to 5%. Most importantly, 1/3 of the deaths occurred in the first 24 hours after the palliation. So currently, this systemic to pulmonary artery shunt remains an option for infants who are particularly unstable presentation, or their anatomy is not suitable for early total correction, especially in case of a tetralogy or fallow. So increasing proportion of BT shunt are being used in the management of single ventricle physiology. If you look at the heart as a circuit, you can say that the biventricular physiological normal heart can be considered as a circuit in series. That means your right ventricular outflow is depending on the pulmonary vascular resistance or the resistance in the pulmonary system. Then the left ventricular output is depending on the resistance in the systemic vascular system. So your right ventricle ejects blood into the pulmonary artery, which is oxygenated in the lung, which is returned to LV, then being ejected into the systemic circulation. So the circuit is in series.